These hormone changes are actually a huge part of why our sex drive is decreasing too,
Yes.
right?
Many women don't realize this, that you and I probably learned later in life. I didn't learn this in residency, that we have more testosterone than estrogen in our body. And you need all of those to affect your libido. It's a losing game because, again, our hormones are constantly in flux. It would be painful to have sex, and it's nature's way of stopping you from wanting to have sex.
Right.
So it's natural and normal. And that's just one of many touch points in our lives as women where we feel bad or insecure or broken or responsible for sex and how we're doing it wrong.
Welcome back to the As a Woman podcast. I'm Dr. Natalie Crawford, and today we are going all the way there because the truth is that most women are never taught how their hormones affect their sex drive, their relationships, or their connection to their own bodies. Joining me is someone who doesn't shy away from the real talk, Dr. Shieva Ghofrany. She's a board-certified OBGYN, cancer survivor, and fierce advocate for women learning to embrace the chaos of their health with curiosity and not shame. In this episode, we're going to talk about what's really going on when your sex drive disappears, how hormones like estrogen, testosterone, and cortisol shape intimacy, and why open conversations about pleasure, pain, and desire are long overdue. Whether you're navigating TTC, perimenopause, or just feel disconnected from your libido, this is a safe space to get informed, feel seen, and take back the narrative. So let's talk about sex. Welcome, Shieva. We're so excited to have you here today.
Hi, Doc. And I love talking about sex.
I know you do,
so
and you're the
fun.
perfect person to help break down this topic without any shame and really to just help educate, because that's the way that we can advocate for ourselves the best.
Yes, we really need to. More and more and more.
I totally agree. Well, we're going to start by just talking a little bit about the science, educating about hormones and biology. So I'd love it if you would break down a little bit about what goes into libido, which hormones are important when it comes to sex drive.
Well, I'm sure you and I know this very well, that is a complicated question and
is.
it's not so easy because for women in particular and people who are born, assigned female at birth, the hormones aren't so straightforward. Of course, estrogen is a huge part because estrogen is how our cycle cycles, and then you have progesterone in there. But many women don't realize this, that you and I probably learned later in life. I didn't learn this in residency, that we have more testosterone than estrogen in our body. And you need all of those to affect your libido. On top of it, you need things like your cortisol to not be out of whack because of things like work, childbirth, stress, loss of sleep.
That's stress hormone. It gets
all
you.
of those things, right? So, and then over time, our hormones change. Our testosterone starts to go down in our 30s. So again, for women, it is so complicated that there's really no easy way to nugget it other than to say, you need all the hormones. You need them not to be in balance because they're constantly in flux every single day, but you need them to be working optimally, and that's not an easy task for women nowadays.
I agree. I think one of the hardest times comes right around that perimenopause transition. And so perhaps we're younger, and as we start to get to this place of less hormone regularity, a little more unpredictability to when our estrogen is going to rise, and essentially having more low estrogen days out of the month than previously we might have had, that starts to lead to other changes when it comes to pelvic health as well, right? When it comes to even the vaginal integrity.
Yes.
Can you explain what starts to happen as estrogen drops to our vaginal health in general?
Yeah, and I love that you said regularity as opposed to balance because I think you and I know it's a big buzzword out there where women are being told really erroneously that they need to be in balance. And it's a losing game because, again, our hormones are constantly in flux, but ideally they're in flux in a way that is regular, like you had said, right? And then we have perimenopause, which can start as early as your late 30s to early 40s. For some women, even in their mid 30s. And it means that your hormones are regularly irregular, or as I joke, predictably unpredictable. And that means that your estrogen level is going from super high one day to super low, and then 3 days of high and 2 days of low, and it's all over the place. And the end result, besides mood changes, libido changes that are affected by lack of sleep, hot flashes, weight around your middle, all of these things, the end organ, which is your vulva and your vagina, and your urethra, get profoundly affected by the lack of estrogen. And that causes pain on top of it or urinary tract infection. So you have this entire kind of spasmodic time where you're just not feeling your best.
I see a lot of women who don't even know they're in perimenopause because they're trying to get pregnant. So they come in for a fertility evaluation and they've started having changes to their cycle, and we find out their ovarian reserve is very low and start really talking about what's actually happening with their ovulation. And they realize a lot of these symptoms they've been feeling, low mood, fatigue, weight gain, decreased energy, it's not just quote unquote getting older.
Right.
It's actually hormonally related to this time period of life that a lot of people really keep in silence, which is we talk about menopause and we talk about trying to get pregnant, but this zone in between, or what happens to our bodies, can be a huge transition. These hormone changes are actually a huge part of why our sex drive is decreasing too,
Yes.
right?
Yes. I mean, I think I love, again, that you're noting that for the women who are trying to get pregnant, because I think more women should hear about it so that they don't, I'm sure they do what they do to me in the office. They look wide-eyed when you say perimenopause, because to them, they've never heard the term. Perimenopause equates being old.
Right.
And that means you can't get pregnant, which you and I know is not true. You can definitely get pregnant, sometimes spontaneously on your own during perimenopause. Sometimes you need help. But so I think that we need to do better by talking about it. Your sex drive does go down potentially during perimenopause, but I think what's really valuable to remind people, if they don't know it, is that while our testosterone levels will go down, that can affect our libido, as can, again, fertility treatments, anxiety, the fact that at the same times that you're mid to late 30s, early 40s, your parents are getting older, maybe while you're trying to have children, or you already have young children at home. But in addition, it also represents a stretch of time where you've probably been with the same partner for this more than 3 to 5 year stretch, where some of the data has shown that our frontal lobe changes how we actually look at our partner. So it's not so much that your libido is down, it's that your spontaneous desire is down. And I find that when I describe that to women, many women will say, oh my gosh, you're right, that makes sense. If I say, for example, libido to me is that feeling of like I want to have sex all the time, but the truth is that's really spontaneous desire more than libido. So if a woman says, yeah, you're right, when I think about it, when I get myself in the mood, I can still have an orgasm, I can enjoy it, then that's probably spontaneous desire, not exactly libido. And again, sadly, that comes from longevity in a relationship, which a lot of women, when you highlight to them, like your divorced friends are kind of raring to go at the same age, they recognize the truth in it. It doesn't mean we should change partners every 3 to 5 years, but it means that recognizing it means you're not broken. It's not going to be necessarily an easy fix. It doesn't mean everyone should be thrown testosterone right away, though there is maybe a role for that in the future. And so I think that it's so complicated again. And if we don't talk about it enough, then people are left just thinking they're broken and there's something wrong.
Well, I think you're highlighting it represents that it could be multiple things. We have to look for medical problems that could be underlying, hormonal issues that potentially could be contributing if you're going into low ovarian reserve early or perimenopause, but also the work that it might take with a long-term partner to bring back some of that spontaneity or that desire, or at least carve out time for intimacy, because that's an important part of a relationship.
Yeah, it really is. And I think what's sad for us as women, for most of us, or at least whenever I talk about it with my patients or friends, we want what we had when we were younger.
Yes,
but the truth is,
we always want what we had.
But we're equating it with when we were younger, when in reality, it's when we were in the earlier part of any relationship. So the sad news is if you're in a long-term relationship, that spontaneity goes away, but you can work on it. The good news is that it doesn't mean, oh my gosh, you're getting old and it's never going to come back. It means you can kind of foster that and kindle it. And if you happen to be in a new relationship, you know what we're talking about, that your libido and your spontaneous desire is back. So I think we can play both sides of the fence by recognizing that we're getting older, but also just highlighting that these things don't have to mean something terrible. I mean, getting older, I think you and I both agree, I'm a lot older than you, but comes with a lot of gravitas that I love. That's so different than what I had when I was younger.
Oh, I know. I feel like I can just do whatever I want.
Yeah.
And, less F's to give about everything else, right? I'm free to be my own self.
Yes.
I have a question for people who maybe are on long-term contraception. Yeah. So I know there's sometimes concern about things like continuous birth control pills or progesterone IUDs and how they may impact our sex drive, our libido, or our intimacy.
It's true. I mean, here's the tough part. I think right now we're in a particularly challenging part of our nation when I really want women to be able to have access to birth control because you and I especially want them to be able to build their families or not build their families when they're ready.
When it's ready for them.
And so birth control is really important. And telling women that they should just be able to look at their cycle and measure their ovulation based on things like salivary testing or their temperature or other parameters.
It's a little risky.
It's very risky. And I always say it's really privileged, meaning many women, regardless of whether or not the resource, just don't have the time to do that. So we want them to have access to good birth control. That said, you and I would both agree, birth control is not perfect. No doctor would or should say that birth control is without risk or side effects. And one of the common side effects, to your point, is when you have that continuous contraception, especially when it's combined oral contraception with these progestins, the synthetic progesterones. Yeah. And sometimes the intrauterine device, though less so it seems because that's not getting as systemic, but both can really affect your libido in ways that decrease spontaneous desire, maybe even earlier, even things out, and actually even have an effect on your vulva and your vagina. Again, you can have what we're now calling genitourinary syndrome of menopause, but you can have the equivalent inelasticity of that tissue, and it's genitourinary syndrome of contraception. And a lot of young women don't realize that. And so again, they think they have yeast infections.
Something's wrong with them.
There's something wrong with them. They're broken, and it becomes a cycle. And that can sometimes lead to really long-term issues with their sexuality. So again, it doesn't mean the pill is bad. It doesn't mean the IUD is bad. It means we have to know what the risks and the side effects are.
I agree completely. What I always say is we've just done a really bad job as a whole of medical providers as educating about contraception and some of these side effects. Because if you know what to expect, then you don't go down this pathway of something's wrong with me, I have this problem.
Right.
You might say, okay, well, this is a really effective contraceptive option, but maybe I'm going to try lubrication or something else because I know this might be something that is a consequence of me feeling safe having intercourse right now. But instead, we don't really talk about the sexual side effects very often. And then patients are left on their own or in the dark when it comes to something that's really important in their life.
Or on the interwebs. But I think the biggest reason, you and I both know this, is we don't have time with our patients. So I fault the clinicians sometimes, but I also fault the system because people like you and I want to talk. I mean, I talk a lot and I talk fast, right? But we just don't always have the time, which is too bad. So it's a good thing we're educating in places like this.
And I think it's important for patients to know how to advocate for themselves, what questions to ask, just to be prepared. It doesn't mean that it's not a great option for contraception, but it's about being prepared and knowing what to expect.
Yes. Imagine if they had a library of all of this information that they could go to before they went to their doctor so they could enter into that 15-minute conversation at a higher level already. Right.
Not talking about every single option, but maybe highlighting two that are appealing and hearing the pros and cons in a better way.
Yes.
All right. Well, let's talk more about the real world and what's happening.
Yeah.
I know you take care of so many women in a variety of life stages. Do you have any stories you could share with us about how this might present to you in the clinic?
My gosh, I feel like I have so many stories, and these end up being kind of an amalgam of many different women. Right. I joke with patients all the time that you want to be unique in the world. You want to kind of show up as someone different. Unless it's your medical health. When it comes to your medical health, you want to be common like everyone else. So when a woman says to me, I have something really embarrassing to tell you, I have something really unique, I kind of joke like, I am all ears, I'm waiting. But the truth is, it's never going to be that embarrassing unique because you and I hear these all the time. So I would say one of the most common things I see is at that 6-week postpartum visit, when a woman is at her peak of exhaustion, she's breastfeeding potentially. She has either had a vaginal birth where you're left feeling really just anxious and, in pain, or potentially feeling insecure about how you just look and everything, or you've had a C-section where you're also in pain, and on top of it, you're exhausted because you've been breastfeeding, your cortisol levels are probably crazy, and your baby is up and crying. And then at the 6-week visit, you are told by your doctor, hey, 6 weeks, you can have sex and you can exercise, which I look back on my former years when I was a young doctor, and I would say that to patients, and I'm horrified because now I'm glad that I take the time to say, guess what? It's normal and natural to not want to have sex, especially if you are breastfeeding, because when you lactate, you and I know, you suppress ovulation. That makes your vulva and your vagina so inelastic that it would be painful to have sex, and it's nature's way of stopping you from wanting to have sex. So it's natural and normal. And every now and then, like this week, I saw about 6 postpartum patients in one day, and 1 out of the 6 said, really? Because I'm actually excited to have sex. And I said, well, you're a unicorn. That's amazing. But guess what? She actually was in the freshest of all the relationships. She had only been with her partner for 3 years. So does that have something to do with it? She was still breastfeeding, so it was a little surprising. But we also talked to them about vaginal estrogen and how much that can help. And I really try to just highlight with them that it's okay if they don't want to have sex. They need their partner to know it as well. So I'm happy when the men hear it, and I try to talk to them about it even at the hospital and tell them that their partners are not broken. But I think it's something we need to be more vocal about publicly so that women don't continue to feel that. And that's just one of many touch points in our lives as women where we feel bad or insecure or broken or responsible for sex and how we're doing it wrong.
Oh, I think you're just highlighting so many important points and this common theme of really suffering in silence for so many people. And I see that, well before even menopause, so many women do have hormonal issues that can result in low estrogen. They're not ovulating as much. And whether it's hypothalamic amenorrhea, or they're breastfeeding, or they're on long-term contraception, or even they have PCOS, which I often hear PCOS patients thinking something's wrong with them because they know they have these androgens. They feel like their libido should be higher, but they rarely ovulate and their estrogen is so low. So they're just really feeling like they don't have any desire at all. And I think that it's important to know that this can be, quote unquote, normal in a lot of different scenarios, but there's so much shame and stigma patients are embarrassed to bring it up.
Yeah.
Like you even mentioned, they say, oh, I don't even want to say this, or oh, I feel so alone.
Yeah.
How do we start to break down that shame and stigma?
I mean, I think we have to be better, again, as clinicians about naming it and saying it. You and I both know the data that if you don't ask a patient, for example, about her urinary incontinence, she won't voluntarily say it. And I learned early on in my career when patients after the 6-week visit, where I was all cheerful before I had my own baby, of like, oh, you're going to go back to having sex. And then by the time they'd see me in 3 to 6 months for their regular annual exam, I would kind of dip my toe and say, how's it going? And they would each kind of gingerly admit that they hadn't had sex yet. And they were so embarrassed. And I started to realize this is the norm. This is okay. So I think the only way we can do it is forums like this, where we're publicly, casually, compulsively repeating this narrative. And we're also bringing it up with our patients in the office, because many of them are taught, again, like you said, that, I keep joking, how much suffering is enough suffering. Like postmenopausal women will often say, well, I feel fine. I don't think I need anything. And if I inquire, oh, okay, meaning like even sex, it doesn't hurt? Oh, well, of course it hurts, but isn't that what it's supposed to do? And the answer is, well, by nature, yeah, but by nature, we were also supposed to be dead at 55. So like, we can go around that. We can fix that. So we need to make sure they understand that it's okay to tell us and that we have ways to fix it.
I love that you're really pushing back against the society narrative of bouncing back, right? Whether it's bouncing back from childbirth or, going through perimenopause or menopause is a huge hormonal transition for your body. It's like puberty in reverse, except you're at a much later stage. And if you're in a long-term relationship, that can also be stressful for your relationship. It can be stressful for your job. And trying to figure out how to navigate that can be really, really tough.
Yeah.
How do you help tell women like to support that? That idea that it's okay that things are different and giving yourself grace.
Well, I try to, I try to do everything that I do and everything I talk about with them with a little bit of humor to make it clear that it really is like, this is just a part of our lives. I also try to differentiate between what is normal versus what is common. I always say normal is what should happen, common is what does happen. So when we talk about perimenopause, I go through, before they've often told me, I'll try to list the laundry list of most common symptoms, because then they see themselves.
Get to say yes.
Yeah. And I see their eyes go wide with, oh my God, she gets it. And I always joke, see, because you're not unique. And that's a good thing. And so again, I think, like I keep saying, you and I just repeating this over and over until we get as many millions of women who can hear it and understand that they have places to go, which we know the data. It's sad that despite us talking about this a lot, something like 4% of women even are on hormone replacement therapy, for example. So clearly we're trying, but we're not getting out there enough. But I think, again, compulsion and humor and repetitive sound bites that women can really identify with is the best way to go about it.
Yeah. I also think it's safe to say it's important to have a good relationship with your doctor, especially during life transition. So maybe you're going through infertility, or maybe you're going through perimenopause or menopause. The doctor that you have a relationship with, if they are not making you feel seen, and the system has issues, but if you bring up concerns, you shouldn't feel dismissed by them.
Absolutely. I mean, I say all the time, I never want to blame the doctors who don't know, especially about menopause, because you and I know we were not trained adequately in residency. I don't want to blame the doctors who don't know. I don't want to blame the doctors who don't have time, but I will openly blame the doctors who don't know, don't have time, and rather than say, I don't know, let me refer you, they kind of do the proverbial pat on the back. You're fine, honey, you don't need anything. And that is, and you and I both know that sadly, that is not just the men in our medical society. It is the matriarchy supporting the patriarchy. There are a lot of female physicians doing the same thing. So that's deeply upsetting to me, because I feel like we are the ones who really should be making this very clear that we are here to help, and if we don't know how to help directly, we'll find them help. And that's our burden, regardless of the amount of time we have to spend.
Agree. But feel like you can, if you're a patient, go see somebody else.
Yes.
Right? That is accepted, that's allowed. You need to have somebody who you feel like has your back as well, and that you can ask these. Maybe they seem embarrassing questions to you. They're not embarrassing to us.
They're not embarrassing to us at all.
Yes,
right?
but you need somebody on the other end of that who's going to help support you.
Absolutely. I think the minute you think someone's making you feel uncomfortable for whatever reason, then you should switch to a different clinician, which is hard. It's not really easy to find people. So I say that, again, from a place of privilege, but you don't want to feel uncomfortable, especially like you pointed out, times where you might have a transition, or God forbid you're being diagnosed with something, or when you just have questions. You really need to be able to have someone that is accessible enough that you can talk to them emotionally. Yeah.
How do you recommend that women bring this up maybe to their partner? Because obviously one big issue is intimacy struggles between couples, and they just don't ever talk about it.
I laugh because if I look at my demographic of who, for example, follows me on Instagram, it's like 98.2 or something like that % female, right? But I have tons of partners of my patients who, when I'm delivering their babies or they're at their visits or they're at the 6-week visit or I just see them out and about town, the husbands will say, every time she's watching your Instagram while we're in bed, I listen as well. And I always joke with them, like, you should be following us. But the truth is, I do think if they hear us saying these things preemptively, then even the male partners will see themselves in these situations. And I think there's nothing better than recognizing that we all are overlapping Venn diagrams of having the same types of issues, right? So I think that's the best way. If you don't feel comfortable directly talking to your partner, then have them watch some of these videos or have them listen to these podcasts, because then it's proof that it's really okay. Like, this stuff is pretty normal. We can get around it. It's hard, but we can do it together.
In a way, I always tell my patients, well, it should make you feel better, hopefully, in your relationship. You're trying to get pregnant, but maybe it's stressful, libido's down, intercourse is not something you want to do, but you want to get pregnant. But bringing this with your partner and hearing that, there might be reasons why, and maybe it's your PCOS or maybe it's your low ovarian reserve, makes it feel less about, oh, it's a problem in the relationship. It's more, this is a hard time, there's other stressors, cortisol, as you mentioned, and that almost makes you and your partner a team trying to get to the bottom of it. Versus sometimes I think partners think, oh, maybe it's just me if we don't open up this discussion.
Right. Well, and I think they can go both ways, right?
Oh, yes.
Either the partner thinks, God, it must be me, she's not attractive, or they think, oh, it must be her, she's broken. And I think you hit the nail on the head. I think many marriages don't start as a true partnership, or what my husband and I have recently learned in a couples retreat, a couple bubble. No one instructs us at the beginning. Just like we don't get instructed about OBGYN health. We don't get instructed about how to couple together. And I think if we did get instructed really explicitly before we got married, it would be so miraculous. It would save marriages. It would save money for the system, everything. Yeah.
I always say when you go through IVF and you have to talk about your embryos and the disposition of them, right? Like what's going to happen if you divorce or this person dies or that. It's a lot of hard conversations. Ethically, it kind of challenges some of your beliefs. And I say this is a really important moment in your relationship to learn how to communicate openly and honestly about hard conversations.
Absolutely.
Because you've got to feel like you're a partner together, but just so often that maybe isn't how you're taught to be. You ride off this emotional high from early relationship into the day-to-day without knowing how to sit down and say, hey, I'm struggling right now. Let's tackle this together.
Yeah. I will say that I had 6 miscarriages, 2 before my first child and 4 after. And they were really hard. I was an OBGYN. My husband, who was a wonderful human, but very much took the road of like, well, she knows what she's doing. She clearly doesn't need my emotional help. And that was absolutely furthest from the truth. And he was just unskilled. And we were unskilled together. And so now, 26 years later, we're really working on it. But it's hard because we've been married for so long. And so to your point, when you're going through these things, it is so important to get help and recognize that very few couples probably would do it great on their own without some form of instruction. So again, you're not alone if that's a struggle.
Let's talk about what you can do about this. And let's go real, medically at first. So let's talk about when is it the right time to consider vaginal estrogen?
Oh my gosh. Well, first, the most obvious would be when you are peri or postmenopausal, and you could wait until you're noticing changes, meaning you're having difficulty with pain with sex or pain when you're wiping or pain when you're spinning, for example, or recurrent urinary tract infections. But there is a little bit of a thought process now that maybe you don't have to wait for those symptoms. Maybe if you're in that stretch where you're in your early to mid 40s, you can start preemptively using vaginal estrogen. And I don't know that there's a right answer yet, but it's a little bit like I always joke, if I stopped my neck wrinkles before they started, it probably would have been easier than like chasing them, right?
Always. Prevention is always a little bit easier.
A little bit easier. So that's one clear time to use vaginal estrogen. And you and I know the preponderance of data is that it's very safe and it does not get systemic. Even in breast cancer survivors, we know good data that's been recently published. And then the second and third times would be when you are postpartum. If you are lactating and you are postpartum, or even if you're not lactating, if you're not getting your period for that first couple months, your vagina and your vulva can be really inelastic and painful. And not just for sex, but again, your underwear, wiping, anything. And third time might be when you're on combined oral contraception or the patch or the ring or even the progesterone IUD. So those are 3 times in your life, which encompasses a lot of
your
years.
Life.
Yeah.
Right. We use it a lot. In a fertility clinic, we're always looking at your lining. We're talking about hormones. And I think there's this idea that, well, if I use estrogen, then I'm not going to ovulate and I can't get pregnant. And even though that might be accurate in high doses, of course, because estrogen will talk back to the brain and suppress ovulation, in very low doses, it can be a supportive option. And this is highlighted by the fact that some young women who go into premature ovarian failure, when we put them on estrogen replacement, because your body needs estrogen, especially if you're young and you're going through these transitions early, your body's not meant to be low estrogen.
No.
But when we put them back on estrogen replacement and their FSH drops from their brain and they'll start to ovulate again.
Yeah.
So it's really highlighting that it's not necessarily suppressing ovulation, which also means it's not contraception. Important point.
Yes.
If you don't want to get pregnant and you're just trying to have better vaginal health.
Right.
What do you talk about, hormone replacement therapy, maybe as a whole versus vaginal estrogen? You and I know these are the same thing, but people often, they can be really different too.
Yeah,
so how do you break
and I
this
do
down?
try to break them down for patients. I typically, if I say HRT, hormone replacement therapy, or now the newer vernacular we try to use is MHT, menopause hormone therapy, which I don't really like as a term, but that's what they're trying to use. I usually reserve that term for the more systemic therapies, really like the patches or the vaginal ring that gets systemic, or the pill, meaning something that's going to affect your systemic hormones as opposed to your local vaginal and vulvar hormones. And I use the term local estrogen when we're talking about vaginal and vulvar estrogen, just because I think it is valuable to be able to concretely separate them, because so many more women even can use local vaginal estrogen and need it even when they're younger. I think we are finally at a place where we're starting to learn that millions and millions, if not billions of women can and probably should be using hormone replacement, HRT, when they're peri or postmenopausal, but we don't have enough guidance from Menopause Society, American College of OBGYN to kind of concretely tell us that, yes, put everyone on it. They have kind of limited our ability to only put a certain subgroup of women on it for now. But I think you and I know that the data is evolving. Right. And so people have to be patient because the doctors have to learn the things that they didn't know before.
And there was recent data about estrogen use and, as you said, menopausal genitourinary syndrome, right?
Yeah. Oh, yeah.
That using estrogen can prevent urinary tract infections,
Absolutely.
sepsis, and death, which can be a major...
Yeah. I mean, we have known for so long that using vaginal estrogen is really going to prevent urinary tract infections. And I think a lot of people look at it as like, no big deal, UTI, just take some antibiotics. But first of all, they're terribly painful. Second of all, like you said, they can lead to sepsis, especially in old people, in older women. Third of all, the cost to the system of antibiotic use is skyrocketing, and we know it wrecks our microbiome. So if you could use something simple and less expensive that's really going to help prevent urinary tract infections in addition to helping with sex, there's really no reason to shy away from it. But there's still a lot of reticence on the part of a lot of doctors, especially oncologists, who I know that their singular desire is to keep people alive, but
I see
they're starting to
young
learn.
patients who are suffering, right?
Yeah, they really are. And the urologists are really the ones who have led the charge in this. So you and I as OBGYNs have to tip our hat to the urologists, because even though we theoretically are the ones taking care of women the most, they've really done a great job at spearheading this particular endeavor with urology as far as vaginal estrogen. So it's great.
Okay, testosterone.
Yes.
Go.
Okay, I love that we are finally talking more about testosterone, because again, let's repeat, we have more testosterone in our system than estrogen, which I never knew from medical school. I didn't know in residency. I think I only learned that 5 years ago. So we know that it's important. Right now, sadly, the only real indication, which is off-label, non-FDA approved, but we would use FDA-approved male doses for women. So again, off-label for women. And we would use it only for postmenopausal women who have the longest term, HSDD, hypoactive sexual desire disorder, meaning you're postmenopausal, you don't have libido, then your doctor or your clinician can prescribe it for you through the regular pharmacy. These are not pellets. These are not non-FDA approved formulations. They're FDA approved for men, but not for women. But again, off-label, we can use them. And they're very safe as long as you keep women within the regular physiologic dosing. I think what happens is you have a lot of clinicians who are giving very high doses, and it's giving testosterone a bad name. And I think we're starting to learn that it's more than just for sex, that it can help our brain, it can help our bones, it can help our muscles, probably a variety of things because we have testosterone receptors. And then we also have local testosterone that we can use vaginally, because we were realizing even more that part of the vagina and vulva is really sensitive to the androgens, to the testosterone, sometimes even more than estrogen. So it's ever evolving. And the worst thing that happened is that we genderized testosterone and made it a male hormone. And estrogen was a female hormone. We need all three, estrogen and progesterone and testosterone, for us to really be not in balance, but what was the word that you used? Functioning appropriately. I don't remember, but it was so good.
I think one thing that's important, especially postmenopause, when you're not having estrogen, testosterone becomes even more essential in your day-to-day function. And I think when it comes to premenopause, especially if you're trying to get pregnant, I see a lot of patients who are put on testosterone but trying to conceive. And this, of course, is a huge no-no. Because if you get pregnant with a female fetus, taking exogenous testosterone can virilize this fetus, meaning the female genitalia, you and I both know this, can turn out no longer female because they're very sensitive to androgens at a certain time period in gestation and how that determines your development of your genitalia. Also, high doses of testosterone in premenopausal women can thin out the uterine lining, much like progesterone does, but even more profoundly, making it exceedingly hard to get pregnant and even preventing ovulation. So I'll see these young women who went to go see somebody, some hormone specialist, and I always feel terrible for these patients because they know something's off. They're advocating for themselves. They get random hormone levels drawn. And maybe they're in the follicular phase of their cycle and they've got some estrogen and a lower testosterone and a lower progesterone, and they get told they're estrogen dominant, and they'll get put on some pellet that's got testosterone and progesterone in it.
That can't be removed.
That can't be removed. And now they're not ovulating and they have these other symptoms. And some of the symptoms of testosterone exposure can permanently change your body.
I will never forget the patient who I'd known for a long time who walked into my office, and I thought, gosh, her voice sounds a little bit different, a little bit deeper. And she had been a weight trainer. And so we were chit-chatting about life, how's she doing, what's going on, how's her family. I go to do her exam, and Natalie, I will never be as shocked as I was that day when I literally looked up and I said, were you going to tell me that you're using testosterone? And she said, how did you know? And you and I both know because I was looking at what was the largest clitoris in the world, clitoromegaly. Right. And again, you and I know, looks like a small penis, and you don't want a very large clitoris like that. And that can be irreversible. And she was being seen by someone who was an MD who was treating her with very high doses. And she had voice changes. She had significant hair growth on her chin and on her neck. And then she had clitoromegaly. And it was shocking. And she actually was really surprised. She said, I didn't know you'd notice.
Wow.
And I thought, oh gosh, so many parts of this are wrong and sad for women in our system, right?
Right. And she'll have permanent voice changes, this clitoromegaly, in addition to being irritating, can cause a lot of pain and other problems. It's not going to just go away.
Right.
I had a similar patient in fellowship, and she was 70 though, but she had an androgen producing tumor. Yeah. So she came in with this deepening voice and this growth down below because of course we don't talk about her anatomy with appropriate terms. So she had a very hard time describing it. And same reaction. I went and looked and I knew exactly why. I said, are you using testosterone? She said no. And right away thought she must have an ovarian tumor. Right. And that's just showing us kind of that hormones are not benign.
Right.
They do have to be prescribed by somebody who knows what they're doing and can really talk you through the pros and the cons. And I always think it's a really big red flag if you're getting hormones from, maybe that clinic within itself, right? If that physician is profiting off the hormone, it's a little bit concerning about do they really understand? Because most of us are going to lean towards FDA-approved medications if they exist. And like you said, even if they don't exist for women, you're using a safe and a tested medication, just a little bit off-label.
Exactly. So I agree. I mean, I never want to paint with a broad brush, but as of right now, I would personally never use pellets because they're not FDA-approved, and the pellet companies themselves have not done enough randomized control trials. And to your point, when people are profiting off of them, listen, as physicians, we profit off different things in different ways, but profiting off the direct sale of something in your clinic, unfortunately, those are the patients that do tend to have these off-the-chart numbers. So I want us to be clear, testosterone can be wonderful when it's kept in the physiologic range, and we can use FDA-approved medications, just not for females exactly, but it's very condoned by our societies. So I do think there is a wild west out there right now, and I think it's partially because the fault of the medical society, because we have not caught up, so we've left the train really open for a lot of people.
Online misinformation.
So much misinformation between not only hormones, but supplements, the whole industry. And so it's a hard time for women, but at least we're getting more information out there.
What about non-hormonal options like lubrication? What do you recommend if somebody's having, maybe discomfort when it comes to intercourse and they say, can I use lubrication?
Yeah. I mean, I would always say yes to lubrication. I think that I look at it in two ways. First of all, I want them to know that there are three different categories. There's lubrication, which I always look at as just like a light moisturizer on your skin. And then there's vaginal moisturizers, things like hyaluronic acid, which actually help retain moisture. And that's a little bit deeper than the top layer of moisturizer on your skin. And then there's vaginal estrogen, which we know really helps with the elasticity. So some women need all three. Some women only need or want one of them. What I don't want to ever do is kind of the classic, like, just use lube, honey, right? Which I find very patriarchal, very patronizing, and often not correct. Meaning, some women can get away with just a little bit of lubricant because they're self-lubricated. They just need a little bit that's going to boost them. And then their vagina is still able to get elastic. But other women notice that when they're just using lubricant, it still feels like a rug burn. Right. And I always explain to them it's because the vagina and vulva are not dry postmenopausally, even though we call it that. I kind of very specifically try to use the word vaginal inelasticity, which is a mouthful, but I think it makes more sense, right? Because if it's dry, what's the answer? Just use lube. But women are scratching their heads saying, I just use lube and now I have a UTI and my vagina hurts. So I really need something else. So I think lubricant can be wonderful. And most women will probably need something else, unless they're, again, maybe younger, maybe only on oral contraception, something like that. They might get away with it. Yeah.
I always say the difference is lube might help for right now, but as you pointed out earlier, some of these other options might be more preventive, right? On a day-to-day type of help versus right in the moment or in the active intercourse. And often we need a combined approach. But I think the heart of this is really feeling comfortable telling your doctor what actually is bothering you, what you're feeling, so that we can make sure that you're getting the right option.
Right. And I think the worst thing that happens is if a woman just says, I just feel dry, and then the answer is just use lube, when you and I both know, again, it's not necessarily dry. There's different things that could be going on. It could be infection. It could be, God forbid, sometimes vulvar or vaginal cancer, which is rare. And often it can just be signs of hypoestrogen, which means the lubricant's not going to work the same way. Yeah.
What about pelvic floor therapy? Where is there a place for that?
So amazing. Like my youngest is 14 and a half, and I laugh because every day I tell my patients in the delivery room, whether they've had a vaginal birth and often with a C-section, have you heard of this thing called pelvic floor physical therapy? Because it really is so impactful for their vagina, sometimes for their vulva, sometimes for scarring. Often if you've had a C-section, because they can help with the scar and they can help with that abdominal wall separation. I still laugh at myself at like the arrogance of youth. I remember 22 years ago when I just graduated from residency and a patient says to me, she had 4 centimeter separation of her abdominal wall. And she said, I'm going to go see a pelvic floor physical therapist, which I had never heard of. This was 22 years ago. This didn't exist in our world. And I kind of internally, because I wouldn't to her face, rolled my eyes and thought, And I'm sure I thought that I was masking, being a little, again, patronizing. Maybe she realized I was. And I was like, oh, that's great. You should absolutely do it. And if it doesn't work to help your abdominal wall, then you come tell me and I'll refer you to surgery. And she came back 6 months later. And don't you know, it worked. And still back then, we just didn't have access to it. Now we have so many more. I mean, the hard part is they're not all covered by insurance because they get paid terribly by insurance. But luckily, women at least are learning about it, and many will have access. It's not a perfect system, and it does mean like one more thing women have to do to kind of collect their body up after they've had a baby. But at least we're learning more than when I had children. So that's a good thing.
I know. I think it's really just changed, even from back when I was in OBGYN training, and we never brought this up. And now I see patients all the time, and I talk about it even if you're having difficulty with speculum insertion, difficulty with intercourse or penile insertion, or if like the vaginal ultrasound is causing you pain and discomfort, that there are options. And some women have, medical issues like vaginismus that can be worked through with somebody who's properly trained to help them with that.
Yeah. And that's a place where it's so important to find someone that you really feel comfortable with, because we should be clear that pelvic floor PT is very internal.
Very intimate.
They get right in there. And I mean, some of the people that are local to us are so good. I always joke they should charge a twofer because they're pelvic floor physical therapists. They end up being emotional therapists because you and I know so much trauma is trapped in our pelvis as well and can be really, really improved and fixed through that type of therapy. So it's great.
You talk a lot about embracing the chaos of womanhood. How do you apply that when it comes to discussions about intimacy and sex?
I mean, I think that's probably the hardest one because everyone has such a different view, and some people still kind of bristle at the thought that we shouldn't talk about it so openly. Even my mother, who, God bless her, is a incredibly healthy, very, very forward-thinking 85-year-old retired pediatrician herself who came from Iran and, blazed trails. But she's every now and then like, do you have to say everything so openly? And the answer is yes. Why don't we? Right. I mean, why are we so quiet about something that most people in the world do? We're kind of supposed to have sex. And obviously, if we're living longer, we know that the value of sex for our brain is great. So I think the best way to approach it is just to keep making it clear that it can be messy, it can be challenging. But I will say I struggle with that myself, right? I mean, 26 years together and things are different. And so it's really hard as a woman to not feel self-conscious about so many aspects of how your body's changing and how you feel and how you look and how excited you can get. And do you need to use, erotica? Do you need to use a vibrator? Things like that. I think it just makes life more challenging. But I think that now we're finally talking about it. I mean, the number of vibrators out there is shocking, right? It's amazing. And we talk about it all the time. So it's great.
I think that's the key, is that you don't have to be shameful. There's no stigma about this. Intercourse and sex and intimacy, they're going to vary, ebb and flow throughout your life. You're
Yep.
going to have challenges at some point. At some points, it might be easy. And that's all okay. And you should be able to embrace knowing that sometimes you might need a medical evaluation to make sure there's not something else going on. And maybe at other times, it's just working through something with openness with your partner, or trying to bring in more spontaneity to the relationship, or going to therapy even to work through some of those difficulties communicating.
And I think recognizing, I love that you say all those things because I think they're all so important. I think also recognizing that every relationship is so different. I have people say to me all the time, like, is it okay that I have sex once a week or 3 times a week or once a month? And the answer is always, I don't know if it's okay. Are you okay with it? Meaning, if you're satisfied and your partner's satisfied, then it's totally okay if you never have sex. Some couples are truly satisfied on the emotional level. But I think many of us know that many of us may not be having sex because there's something else going on. And we know that in our heart. So we can tell what's really normal or not. I think when women are asking that, they kind of want to really just gauge, like, what's the average meter? And the truth is, I have no idea. And I think the data is deeply flawed because I'm sure no one's honest. But I always say very seriously, even though I say it jokingly, if you're having sex regularly, even like once every week or two, that's amazing. And if it has to be scheduled, it's okay. A lot of sex therapists are very clear. Like, if you schedule it, that's good. That's all right. It doesn't have to be this kind of amazing episode each time, right?
I think that's such good advice. We end each episode by asking our guests one key to your health that you wish all women knew. Any last words of advice?
I'm going to give a totally amorphous one. Because, of course, I should say, eat more protein, lift weights, both of which I wish I did when I were younger. I so wish when I were younger I loved my body the way I should have, because I'm very convinced that my weight issues were partially the food I was eating, but largely the self-flagellation I did over the food I was eating. So it sounds so corny, but the best health advice is really, 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 like, no one is perfect on any level. So if we could really encourage our girls to love themselves, God, it would be so transformative, right? In every way.
It's so impactful. I mean, love your body. You only have one. Take care of it and learn to appreciate it, even at a much younger age.
Yes, because that would probably stop a lot of the crazy things that happen later.
I know. Well, Dr. Ghofrany, it's been so great to have you. Can you tell everybody where we can find you and follow and how we can support you? I'm
mostly, from the social media perspective, on Instagram at Dr. Shieva G, which I love because, I don't know if you remember, but I used to be Big Love Fierce Choo-Choo, and actually your sister was one of the people who said you should really change it to your name, and I was deeply sad. But Dr. SHIEVAG has vag in it.
So perfect.
Which is so funny. And then my website is drshievag.com. And I actually just started my own private telehealth perimenopause menopause practice.
That's
for
incredible.
People who are in Connecticut and Florida. While I'm still delivering babies with my private practice with my partners, but I'm doing telehealth separately because I think that women really need someone who they can spend a lot of time with. And I'm sad that not everyone has access to it because insurance does not reimburse it that way. But I'm really trying to help the women I can by giving away as much free information as we can in episodes like this, but also the people who can, kind of from a resource perspective, do a deeper dive and want that. I'm happy to do it for them through telehealth.
Do they find that just on your website, or is there a different way to find you?
Nope, drshievag.com.
Okay, I love that. Well, thank you so much for joining us. And thank you so much for listening to this week's episode of As a Woman. Can't wait to see you next week. Thanks, friends. Thank you for listening to the As a Woman podcast. Please consider subscribing, sharing, and leaving a review so that other women can find their formula for health. For more on fertility, hormones, and reproductive health, follow me at Natalie Crawford MD or visit nataliecrawfordmd.com, because knowledge is power, and your health deserves a formula made just for you as a woman.